Right, so we're going to make a start. My name's Vicky Hutton and I'm from the Melbourne campus, and my contact details are on the front of that booklet. This is quite disconcerting for me because usually I teach on the Melbourne campus and I know some faces. I don't know any of you. So, also I want to say thank you for coming in on the 12th of January. You're all probably in holiday mode. Yeah? Yeah, you can admit it. And I bet you woke up this morning and it was that, why did I agree to do it? Oh, I had to do it. So anyway, we'll make it well worth your while. I'm going to, as you know, I'm going to run through CBT with you. And more from, we'll go through a lot, we'll go through techniques, but more as a refresher, it's by no means a comprehensive CBT course. It's more just to familiarise you with quite a few of the things that you may be meeting in your placement. And also just to give you an idea of how you can use the counselling skills that you've got, because I know probably one of the biggest complaints I hear about CBT is that it's very clinical, it's very structured, and anyone here have that perception or have that feeling that it's not really what they're interested in, but they're doing it? Yeah, thank you for admitting it. Yeah, I think there's a seat there, and Aaron's organised.
Coming out of the woodwork, Vicky, I apologise, I don't know what happened.
That's all right.
Can you just take that seat right there?
Yeah, and Aaron's getting a few more handouts. So if you just want to sit there for a moment, Aaron will sort that out. So yeah, got one person who admits that they've got the perception that CBT is a little bit clinical and a little bit structured. And that's fine, because the common perception is that it is. Purely because it works through a set of stages to get something done in a certain time. Now, that doesn't mean that you still don't need your counselling skills. In fact, you probably need them more, because a lot is expected in CBT. There's a lot of work to do, there's tasks to do, so your counselling skills to build that rapport are essential. But what we're going to do today is just work through what CBT is. I know you did it, most of you would have done it in your earlier units. I should have mentioned I'm the convener of the Graduate Diploma of Counselling, so I'm very, very familiar with the Grad Dip unit that covers this, and not so familiar with the Bachelor and the Master's units. Have we got any Master's students here? Yeah, Grad Dip students? Yay! Oh, and Bachelor students? Excellent. So what I'm covering applies to everyone. Now, I've put together a bit of a workbook purely so that you're not watching a screen, you're not desperately taking notes and not focusing on what I'm saying. Sounds so egotistical, doesn't it? No, more for it, and also so you've got something to take away with you. And I have literally just started it with, why is CBT so important? Why have we dragged you all in here? Why are so many of the placements working within the CBT model? And the simple answer is that it's because it's evidence-based. And as we know in our culture, our society, the minute something is evidence-based, it does attract more funding, because any funding agents, organisations, including the government, like to see an end outcome. And with CBT, for many reasons, you do see an end outcome. So I've just started with a psychology definition of CBT, just so that you know the formal technological techo definition. Don't worry about that too much, but the main thing is that cognitions influence feelings and behaviours, and subsequent behaviours and emotions influence cognition. So that's what the Australian Psychological Society and other psych organisations say is the defining feature of CBT. Not that you have to be psychologists to practice it, because you're all counsellors and you'll be going out into organisations that use it. What is important is why is it so popular? And as you can see, evidence-based, because part of the whole process of CBT is monitoring. So you'll administer some sort of scale before they start, at some point through, and at the end. So you literally have, for both you and the client, an idea of what's happening and where you're getting to. It's part of the Better Access to Mental Care initiative, but that doesn't really involve us too much, only in that in many ways it defines how it's used. Some of our placement agencies use it, and I'm guessing you're all going to placements that use CBT? Yeah. Individual or group? A lot of them both? Yeah. So the way I've structured this is that we're going to go through individual CBT, because you cannot conduct group CBT if you don't understand the basic premises of CBT. So second half we'll get on to groups, but at the moment we're just going to go through in many ways the individual, the relationship. But going through, Aaron kindly sent me a list of our placement agencies and ones that you're likely to go to, and CBT is used for so many different things: mood, anxiety disorders, PTSD, personality disorders, self-esteem, eating disorders, self-injury, suicidal ideation. So,
sorry Vicky, I'm just checking the video is actually working.
Yeah.
And you were supposed to tell me when I moved to one side.
It's all good. No?
But you probably didn't get me then. Sorry. But, okay. So, page 3, the other thing that I just wanted to run through is that CBT there are many variations, different names, and you might go to a place. Am I wrong?
No.
Oh, sorry.
I'm signalling Aaron and he's right behind you. So, just getting another breath.
Okay. You'll go to a range of different places, but they might actually call their CBT by a different name. And you might think, holy crap, I don't know how to do that. But I just want to raise your awareness of the many different names that this modality falls under. So, first one, behavioural activation, and that's largely used with depression, and it's based on the principle that clients are encouraged to do certain activities, which they then find rewarding, and principles of positive reinforcement, so operant conditioning basically. So it's a purely behavioural form, but it's still very, very popular, because what we often find is that if you can get someone behaving in a certain way, their behaviour will then influence their cognitions and their emotions. So that we're always working with the 3. We're never separating, even though this works on behaviour, we're still focusing on cognitions and emotions. Some of you, or many of you, might have heard of rational emotive behaviour therapy. Still that same school. Some places you go to may call what they're doing REBT. So that's the first of the cognitive behaviour therapies, and it's the ABCDE model. Are most of you familiar with that model? Yeah. So I'm not going to go into details on that one. I've put a slight description, but that is another name that you might hear thrown around. Cognitive therapy, that's Beck, Aaron Beck, very similar to CBT again, directive time limited, present centred, problem oriented. Cognitive behaviour modification, and that's more of a focus on self-talk, but not as quite as direct and confrontational. Not so much of the disputing irrational beliefs, but more the positive self-talk. Again, you might strike that. Cognitive narrative approach to CBT. Has anyone done narrative therapy in their training? Yeah. Yeah, so you might be happy to hear that there is a slight merging of narrative therapy and CBT. in recognition that you need to get a person's story, get the plots, the storylines behind it. So that's, then we've got schema-focused therapy. Still same principles, but focusing on maladaptive schemas. And schemas are those psychological constructs that we live our lives by. And some in conditions, especially depression, sometimes our schemas about ourselves and others and the world become a bit negative. So that's all about focusing on those. And then we've got the third wave. I'm not going to be covering these, but just be aware that dialectical behaviour therapy, and I do know that some of the clinics you're going to offer that as well. Originally, it was largely used for things like borderline personality disorder, but now it's being offered for a range of conditions, eating disorders, substance abuse. Still on the principles of CBT, but with a whole lot of add-ins. It's also based on individual therapy, so that didactic, but also group therapy. Usually lasts for quite a while. Borderline, it's up to about 12 months. But if you're working in that area with your clients, you'll probably be you'll be supported with that and helped through. And ACT, acceptance and commitment therapy. Again, one of those, a newer one, still based on the same principles, but very much about reframing problems. So not eliminating problems, but reframing the way a person thinks about problems such as anxiety. So it's not so much getting rid of, eliminating the symptoms, but learning to live with them, to coexist with this sitting next to you. And mindfulness-based cognitive therapy, so big emphasis on mindfulness. Mindfulness, as you know, is growing increasingly popular and starting to feature in a lot of the therapies. So they're just some of the names that you might come across. I should have also said, interrupt me at any time if you've got questions. More than happy to stop talking. I will be getting you to do stuff a bit later, but this early section is me just telling you all about it. But you're welcome to interrupt. So defining and describing CBT as we will be going through it today. Cognitive behavioural model, you would all be aware, involves the situation, thoughts, beliefs, emotions and behaviour. Now, this model sums it up quite well in terms of what happens in a person's environment, influences what they think about it, what they feel about it, and the behaviour. And there's this cycle that goes round and round. So the CBT model, as it says underneath, says it's not actually the situation that causes the emotional distress, it's what you think about it. So if my neighbours are really noisy, and you can tell what happened to me on the weekend, no, that situation really annoyed me, but it was what I was thinking in the middle of the night that was causing my distress. They were doing their things. They weren't making me feel what I did. I was making me feel what I did. The situation triggered my thoughts, which then triggered my anger. Bad weekend. But that's the gist of it. My neighbours weren't, the situation did not make me angry. I made me angry. And my thoughts that what I wished to do to them made me very angry. Anyone got noisy neighbours? Yes. Yeah. So, key therapeutic principles. Therapy is regarded as a collaborative project between client and counsellor. So already you're starting to debunk that myth that it's very counsellor directed. The client just goes along with what you do. Completely false. It is collaborative. If it's not collaborative, if you don't work with the client, if you don't continually summarise what you think is happening, if the client doesn't agree with your ideas, your theories, your hypotheses, you may as well give up then, because the client will not participate in the therapy. Perhaps they'll drop, they just won't come back. Perhaps therapy will stall and you'll be sitting there going, I wonder what went wrong. It will be because it has to be collaborative. And that's where every skill that you've learnt in your course comes into its own. Because for it to be collaborative, you have to develop rapport, you have to ensure that you have empathy, and you have to use all those skills to be reflecting back to make sure you understand that you're both on the same page and that you're both going to address the same problem. Work is problem focused and structured and time limited and informed by research, which means funding agencies love it. We can say beginning, end, we know what happens in the middle, off go the clients, we do relapse prevention, but agencies just fall in love with something that doesn't see a client lingering on for a long time. Short and sharp, working on something, and then when they apply for their funding, next time they can say, we had so many clients through, and then the funding keeps coming, which is a really, not a cynical way of looking at it, but a very practical way, because a lot of you will be going to places that rely on some sort of funding, and evidence-based modalities bring that funding in.
Sorry to interrupt, Vicky, but another key thing for a lot of our agencies is the medical benefits. So when the clients come into the clinic, they're claiming it on MDF, whatever, HCF, whatever it is, they will only pay for CBT.
Yeah. So if you're working under if there's a psychologist and so the client is paying the psychologist or social worker or whoever's number they're using for Medicare rebates, Medicare is very limited to certain focused psychological strategies, so CBT, interpersonal therapy, psychoeducation, relaxation therapies, family therapy, very, very small amount, and CBT is the one that seems to be top of the pile. Narrative therapy in some cases, especially Indigenous populations. But yeah, with the Medicare rebates, so thanks Dee, that's, as you can see, money plays a big part in the work. So role of therapist, look at that, we're on page 5. And I've included this, this pie chart. This is, pie chart? What do you call the round ones? It didn't sound right when I said it. I guess to highlight to you that with CBT, any therapy, but just to show how crucial your role is, because as you can see, this was a study done on variance attributable to therapeutic factors. Therapy relationship, 12%. Individual therapist, 17%. So already 20% of the outcome is dependent on you, the relationship you establish. Now, when you also take in, and then we've got treatment method, which is a very small 8%. So take in patient contribution, 30%. CBT relies a lot on the client's collaboration, participation. And then unexplained variance are things like expectancy. So that whole thing, when a client turns up for therapy, you've got almost that placebo effect in terms of, I'm finally doing something about this, and instantly they feel relief that they're doing something. And what we call extra therapeutic change, which can just be that something out there has changed in their life. But the main thing is that the therapeutic relationship is crucial. 20% initially just to get the process going, and then client contribution another 30%. So as it says, one of the fundamental principles, collaborative relationship. You develop an alliance and you fight a common enemy, which is the client's distress. To establish that, you have to strike a balance between being directive and imposing structure on one hand. So yes, you need structure. You need to, it does follow a format to be finished in the required time. So that's true, it is structured. But you have to allow the client to make choices and take responsibility. They're the ones doing the work, they're the ones doing the homework. So they have to take responsibility as well. it's quite a balance, and we find that in some cases CBT therapists are viewed as quite directive, which is in many ways is where the reputation comes from, it being clinical and too structured. But directive on one hand because it has to be structured, but in complete collaboration with the client goals.
Vicky, you mentioned earlier client resistance to theories and hypotheses.
Mm-hmm.
So are you saying that in fact there is a place for the therapist to hypothesise and present theories?
We're going to do both an assessment and a formulation of a case study. The formulation is basically a hypothesis of what created whatever the presenting issue is.
And that's your idea rather than the client's idea?
Well, it has to be done in... The assessment is looking at what's going on in terms of emotions, cognitions, and behaviours. And then based on that, you collaboratively put together a formulation, a case formulation, which is based on the principles of CBT. And it's basically a hypothesis of what's driving the behaviour. So, and when we get onto what the client needs to be next, some clients come to counselling just to talk, so they will be resistant. So is that sort of what you meant?
Yeah. No,
yeah. And I use the word, you may not say hypothesis to your client because it has scary scientific connotations, but that's what you're doing. You're establishing a hypothesis of why this is happening. Okay, so balance between structure and making choices. Balance involves deciding when to talk and when to listen, when to confront and when to back off, when to offer suggestions and when to wait for the client to make their own suggestions. What you do in counselling, what you've been studying all this time, no different. You also explain a rationale for any intervention. So that's in terms of goals that the therapist has to establish first up, which is part of developing that rapport. Effective working alliance, which I've probably repeated over and over. A safe place, just your counselling skills again. You have to have that safe place so that the client can discuss what's important. You have to help clients see they can effectively address concerns. So you have to, the client has to believe that by the end of this course, they will be able to address concerns. So again, all your counselling skills have to go into that. Show clients you are genuine with them, understand them from their frame of reference, accept them, your normal counselling skills. Establish a communication forum where you both talk freely about mutual experiences of therapy, so a meta-therapy dialogue. As you can see, there are no differences to normal counselling, but essential to get to that stage. Role of the client, what do we need from the client? They need to speak openly about their problems. Be active in the therapeutic process, and that's a key factor. It's not a therapy where they can just sit back. They do need to work. Speak up, giving their opinion about therapy. So they have to feel confident that they can say, no, that's not what I mean. No, that's not right. No, I don't want to work on that. I want to work on this. And undertake to carry out agreed tasks in the service of their goals, because it is to get from beginning to end, they are expected to do stuff. So the clients who are suitable, they can recognise automatic thoughts or images, because as you know, CBT relies a lot on working with clients' automatic thoughts. If a client isn't in a place where they can even recognise them, probably not a good starting place and may not be suitable, because not all clients will respond to CBT. Can recognise and distinguish changes in affect or emotions. So again, sometimes clients don't understand their emotions, don't recognise what's going on. And in one of the DBT, which I mentioned earlier, which is a lot longer and has CBT components, part of that is emotional regulation and recognition of emotions in order to regulate them. So sometimes if they can't recognise and distinguish, you can include psychoeducation. That might be part of your treatment plan. If you believe that they just need a bit of psychoeducation around that area, that can be part of the overall plan. Have some optimism regarding therapy. Accept both responsibility and the need for change. Now, increasingly with CBT, we can employ things like motivational interviewing, which some of you may have done. Anyone done AOD? Yeah, features in that a lot. Motivational interviewing is just a way of getting the client to recognise if they're ready to change. They're willing to carry out homework tasks and are able to concentrate and focus on the agreed agenda. So that's sort of the preliminary of almost setting the scene. Any questions on that so far before we move on to the actual structure? No? Okay. Oh, sorry, Aaron. Was that too far?
No, you're all good.
Might be doing it on purpose. Okay, so shortly I'll be getting you to do an assessment and formulation, which will answer Julian's question about the hypothesis, but we'll just structure. And this in some ways supports that notion that it's very structured, but for some clients, they love structure. Some people turn up to counselling, or some people don't turn up to counselling because they think it's just very airy-fairy and wishy-washy and no direction. The minute they realise there's a structure, they're all in it. Who likes structure in their life? Yeah, me too. Obviously, that's why I'm here. I must admit, I'm one of those people who like structure. I love CBT. I probably should have mentioned I'm here because I have run CBT groups. I find them very rewarding, very hard work, but really rewarding because you're working towards something. So I admit it, I love structure. So structured stage-by-stage program in which the problem behaviour that has been troubling the client is identified and modified. But there are specific steps. Therapeutic relationship, so as you can see, top of the pile, therapeutic relationship. Assessment, really important, formulation, intervention, monitoring and relapse. Now, the reason relapse prevention is really important is that the aim at the end of this is to have the client be their own therapist. So they develop the skills to correct any future behaviours based on what they've learnt here. So relapse, really important. Relapse prevention. Therapeutic relationship, exactly what I've just been saying. Rapport, working alliance. Socialisation of the client to the cognitive behavioural model. Explain to them. Important part of any sort of counselling is for the client to know what's going on, what they can expect, what's going to happen. So explain the model. Warmth, genuineness, congruence, accepting, respectful, non-judgmental, all those things that you do automatically, don't you? No? Anyone saying no? You should all be doing automatically. I shouldn't even have to write those words down because you wouldn't have done all your training and be here if you weren't doing all those things. Attentiveness to the client, accurate empathy, notion of client counsellor collaboration, sharing responsibility for problems and importantly solutions. So there's that word collaboration keeps popping up. Assessment. Really, without this assessment, you stall. And sometimes if some people aren't skilled in CBT, they don't get past this assessment stage, and so you end up meandering around, addressing lots of little things and never actually getting anywhere, which is frustrating for the client and for you. So, but it's not just a list of questions. It's a task where, again, collaboratively that work, you begin to establish a relationship of trust. 4 key domains that you're seeking information in that fit within the CBT model. Cognitions. So what thoughts and images are occurring and how is information processed? You try and be quite specific on this, which I'll talk about later. So words, phrases, images in the client's mind when experiencing the situations. Emotions, so what different states occur around the problem. If the client doesn't understand their emotions, you may have done earlier work just as part of the socialisation to the model, explaining about emotions. For instance, we know that anger as a blanket emotion is driven by many different things, and some people can't recognise the difference in it. Behaviour, what does the person do? And physical, what physical sensations or reactions occur. Really important to get all of those, get all that information, because they're all fundamental to the model that you're working in and to the formulation that you'll be developing. So, page 8. And as I said, you don't want a generalised account. I always get angry when my neighbours make noise. I always get angry when people are yelling in the street. Find a specific. And with me, as you already know, I would be talking about last weekend in detail. So, specific event, because you can actually experience those emotions. If you're relating them to a specific event, things are a lot clearer. So I could clearly describe my cognitions for that event, which I won't. Invite the client to talk about the problematic event and use these descriptions to find out about the content in the 4 domains. Intensity of the experience and sequencing. And then you construct an understanding of how they're linked together. So, any questions so far? Because in a minute I'm going to get you to do an assessment. Okay. There are many ways, all variations on a theme. I've put a quite basic one here, which is a 5 areas assessment. Very clear cut. And the example I've put on page 9 is how you would go about an assessment. So we've got a life situation, relationship and practical problems. So a woman presents to counselling, her husband had an affair and left her 3 weeks ago. Situation. She may actually have presented with lots of other things like, I'm a loser, everyone hates me, I can't do anything right. But as you know, we're narrowing it down. Well, let's find a situation where you actually demonstrate what you've just been saying so generally. And she'd say, well, prime example, my husband left 3 weeks ago. So, right, that's a starting point. Altered thinking. I've been a terrible wife, it's my fault he left, I'll never get another man, my life is over, everyone will think I've ruined my marriage. So they're the sorts you're looking at what thoughts are running through your client's head in regards to this one specific situation. Because the thing about CBT, which sometimes differs from other modalities, is that you're bringing it right down to specifics so that you can work on that and then expand out to generalities. And that's the part where you make the client their own therapist. But the very first stage, specifics, really important. So she's thinking all those things. Altered emotions, feels low, no longer enjoying things, has no sense of achievement, weepy. And then altered physical feelings or symptoms. And this one, in this case we've got sleeping badly, no energy, forgetful. The case study I'm going to get you to work on is the case study for panic disorder, where there are a lot more overt physical symptoms. And then altered behaviour or activity levels. Stop getting up early, lies in bed until 11, which is probably what you've been doing all summer. Except today. Is drinking a bottle of wine at night to help to get to sleep, thought about taking an overdose, stopped answering the phone to family and friends. Clear? It's really basic, isn't it? And I guess that's why a lot of people like it, because it is, you're clearly dividing things into the important areas as a starting point. So what I've given you on page 11, and this is a case study. Have you all know that through our library we can access the DSM? Yep. Just under that same link, you'll find DSM clinical cases, and there's just like this, case studies for every diagnosis in the DSM, just ways that it could present. So this is where this is from. Easy for you to access any of them. And this is a diagnosis of panic disorder. And what I want you to do, and you can work in 2s or 3s, is to actually do an assessment of this client. You're not worrying about history. We'll look at that in the formulation. Your assessment is literally page 10, life situation, relationships and practical problems. And then, which, once you've read through this, you'll see that the situation or the life situation tends to be emergency room presentations with no diagnosis. But what I want you to do is divide it up. I love highlighters. Does anyone know? That's my way of doing stuff. But divide it up into the thoughts that are in this client's head that she describes, the emotions she describes, the altered physical symptoms she describes, and her altered behaviours. Now, you will get all that from this case study. As I say, I don't want to know about past history. You're purely focusing on the specific episode, which is emergency room presentations with no diagnosis. And you're looking at all her thoughts and emotions and behaviour. Is that clear enough? Any problems? So either 2s or 3, go through yourself, what I'd suggest, read it, and then discuss it with a partner, 2s or 3s, because it's often easier to, if you're not sure, just to bounce ideas off. Go for it. So we probably don't need to record this one, do we? And I'll wander around and chat with you once you've had a chance to read it.
Yeah.